Alright, medications that can cause withdrawals. The first two on my list are pretty obvious. First on my list are opioids. The withdrawals are pretty bad. Lots of physical symptoms acutely and then also mood symptoms long term. So what we can do is symptom management. Treat the insomnia, nausea, vomiting, diarrhea, and muscle aches with medications. We can use clonidine or lofexidine for autonomic dysfunction. Patients can also choose to go on medication-assisted treatment. So this is Suboxone or methadone. Next on my list are benzos. Xanax, Valium, Klonopin. Withdrawals are also pretty bad. Panic attacks, sweating, insomnia, and at worst like hallucinations and seizures. If you're coming off a chronic benzo, you gotta taper it cautiously. Tapers can last months. Next on my list is gabapentin. I've had a handful of providers not know that you could withdraw off of gabapentin. Nausea, GI upset, dizziness, insomnia, anxiety, tremors, cognitive issues like confusion and disorientation. I'll mention with this one, gabapentin also has an abuse potential. I would expect withdrawals to be significantly worse in patients who are abusing it. If you're wanting to come off of a medication and you're not sure how, talk to your pharmacist, your provider, whoever's managing your care. Some medications have awful withdrawals and some can be dangerous if you just stop taking them. Check out my part 2 video to see what other medications can have some withdrawals. This is medications that have withdrawals part 2. First on my list are antipsychotics. This is like Zyprexa, quetiapine, Abilify, Vraylar. These medications act on a bunch of different receptors. Adrenergic receptors like alpha-1, they block dopamine. They act on serotonin receptors, cholinergic receptors like muscarinic receptors, and histamine receptors too. Withdrawal symptoms are going to be pretty similar between the antipsychotics, but remember some have different selectivities. You can see some anxiety, nausea, headaches, trouble sleeping, tremors, and with clozaril especially, with abrupt discontinuation, you can see something called cholinergic rebound, so pretty bad nausea, vomiting, diarrhea, and sweating. Next on my list are PPIs or proton pump inhibitors. Prilosec, Nexium, Protonix, Dexilant. Stopping proton pump inhibitors immediately is going to cause something called rebound acid. I see a lot of people on proton pump inhibitors long term where it's not indicated. Long term use of PPIs can cause a lot of issues like C. diff, pneumonia, hypomagnesemia, low B12, and even kidney problems. It's recommended to taper off a PPI so you don't experience that rebound acid. You can decrease your dose weekly and then take it every other day and then maybe even switch on to an H2RA or histamine 2 receptor antagonist. This is like famotidine or Pepcid. And last on my list are SSRIs or SNRIs. SSRIs, this is your Prozac, your Paxil, your Lexapro, your Celexa, fluvoxamine. And then your SNRIs, your Cymbalta, Prestige, Effexor, Fatsima, Savella. SNRIs are going to have worse withdrawals than SSRIs. The acronym that I use for withdrawal is VIVID, so vomiting, insomnia, vivid dreams, irritability, and dizziness. Patients can experience flu-like symptoms and loss of coordination and even brain zaps. One of my friends who was coming off of them said that he was transporting between dimensions. I thought that was insane. But yeah, if you want to come off of a medication, I would recommend tapering off of it. Of course, always talking to your pharmacist, your provider, whoever's managing your care. Alright, this is medications that have withdrawals part 3. Next on my list are stimulants, so Adderall, Vyvanse, Concerta, Ritalin. Methamphetamine, remember, is a prescription drug. You can see irritability, extreme fatigue, difficulties concentrating, insomnia, and even depression that can linger months after discontinuation. Your body adapts to drugs. That's why we see tolerance. Your body actually downregulates dopamine receptors when you're on stimulants. There's actually some mixed literature showing an increased risk of Parkinson's possibly with those that use stimulants, which I'm wondering, is that actually something that happens with downregulation, the drug itself, or those that take stimulants? We definitely need more studies with this. Next on my list are Z drugs, so Ambien, Lunesta, Sonata. These have some pretty bad rebound insomnia. Z drugs act similarly to benzos like Xanax, so you might see some mood changes or anxiety too. Next on my list is nicotine. You can have nicotine withdrawal with both cigarettes and vaping. So with nicotine withdrawal, you can see some irritability, some restlessness, anxiety, insomnia, depression, headaches, and of course cravings. The physiological responses and addictive potential have both a pharmacodynamic and a behavioral component. I'll mention that the speed of onset increases the addictive potential. This is why a lot of illicit drugs are injected, smoked, and snorted. It gives you a better high. But there are some medications that we can use for nicotine withdrawal and smoking cessation. NRT stands for nicotine replacement therapy. So generally it's gold standard to use a long-acting, like a patch, and then an as-needed, short-acting, like lozenge or gum. Remember, we're going to see more steady concentrations with nicotine replacement therapy. For the long-acting, for the patch, if you smoke more than 10 times a day, you're going to start with step 1, which is 21 milligrams. So step 1 is going to be for 6 weeks, step 2 is going to be 14 milligrams for 2 weeks, and then we're going to see 7 milligrams for step 3 for 2 weeks. That's generally how we do it. Then if you smoke within 30 minutes of waking up, you're going to get the 4 milligram gum or lozenge, and then if after 30 minutes, 2 milligrams. I guess I can add a counseling point in here, but with the gum, you're going to chew it and park it in your cheek. You're going to get absorption through your cheek. It low-key kind of burns your mouth and throat too. I'll add. I guess we can also add this, but drinking acidic beverages before you do like a nicotine lozenge or gum is going to decrease absorption. If you remember back from chemistry, look at that, it's an amine, a tertiary amine. Nicotine is a weak base, it has a pK of about 8, so acidic things are going to increase the ionization of weak bases. Charged drugs don't generally cross cell membranes very easily. We see the same concept with drugs that don't cross the blood-brain barrier. I'll also add like glycopyrrolate. But yeah, that was our little chemistry lesson. I gotta always put one in a video, I guess, every now and then.